This is Dr. Neal Mauldin for PetCure Oncology, and today I would like to spend a little time talking about spinal tumors. Spinal tumors are a tumor type that can be difficult to treat and that there is perhaps some risk in treating, although I think the potential benefits of treating typically far outweigh the risks. However, there is some controversy, at least in the veterinary community, over the appropriateness of treating spinal tumors with radiation. I'd like to sort of take you through the stereotactic side of things, particularly the volumetric side of things, where we're treating these patients with ARC. So this is a CT scan in a patient with a large spinal tumor. This is an 11-year-old standard poodle who presented for evaluation and possible euthanasia due to the fact that he had acutely become paralyzed and could not use his back legs and was also in a significant amount of pain. Just to orient you a little bit, this is the CT scan that was done to evaluate his tumor. Left is on the right and right is on the left. He's laying on his chest, so his sternum is down here, and then top is up here. As we look at the study, these dark fields here are lungs. This is the liver here, esophagus. This is the vertebral body, so the bones of his spine. And you can see that they're very disruptive and destroyed, and we've got this large soft tissue mass that is destroying the vertebral body and also extending into the lung cavity. So it's eaten through the vertebral body and is down in the chest cavity next to the lung. Spinal cord is actually fairly difficult to identify in here, but this little guy that's sort of being shoved over and compressed off to the right is the spinal cord. Normally should be a much more round or oval structure sort of sitting right in the middle of the spinal canal. And so that's where all of his clinical signs came from. So this patient's family and I had a conversation about treatment options. Their options were to consider euthanasia today because of the severe amount of pain and because of the rapid deterioration in his neurologic function, or to try and treat him with stereotactic radiation. They elected to proceed with radiation therapy. If we move on then and look at the radiation therapy plan itself, we can see that these are the orthogonal views here. This is the 3D reconstruction. And if we look, we can see that we've got the structures all delineated, so the lungs are defined. Here's the tumor. This cyan or bluish volume is the what's called the clinical target volume, so where we could actually see tumor. This red volume is the target volume, where this is the area that's actually going to be irradiated. And you can see that we've tried to delineate the spinal cord. This pink volume is the spinal cord, and you can see that there's sort of this zone of uncertainty about where the tumor ends and the spinal cord begins. So we included that into the treatment plan itself. If we look at the 3D reconstructions, so we can sort of see the different structures. So these large yellow structures are the lungs. This pink structure is the normal spinal cord, and then this structure is the target volume, or where the tumor is. You can see again that the spinal cord is fairly well surrounded, and you can see how deformed and flattened it is here as it passes through the tumor and as the tumor is compressing it. If we look at the bone contours, kind of the same thing. We can see all the bony structure. There's a large defect here in the vertebral column in here. And again, you can see that their tumor is extending into the inside of the chest cavity as well. If we look at the actual dose that was achieved, we can see that, let's turn the bones off. We can see that the tumor is very nicely encapsulated within that dose curve. The spinal cord is also disappearing in there and getting a fairly significant amount of dose. Although if we really start to turn the dose down to the 95% line, which is usually what we're most interested in, we can see that the spinal cord is being spared a little bit and not receiving the maximum amount of dose. So this is where the risk comes in. Spinal cord is a fairly specific and sensitive organ in the body, and that the length of cord that's being irradiated is a problem. And this is what has led some people to say that it's very dangerous to treat spinal cords because there's blood vessels there that if you damage them will damage the cord and probably irreparably damage the cord. Our argument against that would be to say that while that is true, those events happen 12, 18, 24 months down the road. And so if we have a spinal tumor patient that responds well to radiation and that survives for 2 years after being treated, that's probably a risk worth taking. If we look at the two-dimensional view of the tumor, we can see that this is the 95%, this orange zone. So you can see that the tumor is very, very nicely controlled and contained within that 95% curve. And actually we're sparing and pulling that spinal cord out as best we can. One other thing I'd like to look at just real quickly, and I know that there shouldn't be any math involved, but here there is a little. If we look at the dose statistics for the different volumes, the one we're really interested in is the planning target volume. And the two things we're interested in are called the conformity index and the gradient measure. The conformity index is how well is the tumor being treated. So how much of the tumor is getting 100% of the dose. 1 is ideal. Between 1 and 2.5 is excellent. Greater than 3, we would think that's not as good as we want, and less than 0.9, we'd say that tumor is being undertreated. Equally important is this gradient measure. That's how tightly does the dose fall off from between the tumor and the normal structures, and anything really less than 2 centimeters is outstanding. 3 centimeters is acceptable. So the fact that we've got this gradient measure down to just a little bit over a cm is really an excellent result, because that means the dose is falling off very quickly away from the spinal cord, and that's why we think treating these patients with ARC is really a superior way to go, because it allows us to get the conformity and gradient indices low like we would want them to be for these patients. And then if we go back and look at the CT scan again, so So if we go back and look now, this is the original CT. So again, right, left, chest, top, and the original tumor. So destruction of the vertebral body, displacement of this rib, and then a fairly large component of tumor within the thoracic cavity. And then if we compare that to CT scan done 5 months later, so this was in November, this is in April, we can see several different things. That we've got some nice bony remodeling of the vertebral body. You know, if we look back and forth, there's obviously still not a normal vertebral body, but much better. And probably most impressive is that spinal cord now is much more well-defined and starting to move more towards the middle. And we've got a significant reduction of this tumor volume within the chest compared to what we started at. And probably what is even more impressive from that perspective is if we kind of change the windowing of the CAT scan to focus really on the lung tissue. Lung is a very sensitive part of the body to radiation. It's one of the most sensitive that we deal with, and where the most significant radiation side effects can occur. And if you look at the tumor lung interface here and the tumor lung interface here, there's perhaps a little bit of scarring right along the edge of the tumor, but the lung fields themselves really do look quite good. This patient went on and survived 15 months from the time of his original presentation. His neurologic function returned to normal, and he had a very good quality of life. His final cause of death was tumor recurrence and reemergence of his neurologic signs. At that time, we discussed potentially boosting him and pushing harder with radiation. He was now quite a bit older, and the family decided that that wasn't a path that they wanted to pursue. But these are the kind of cases that do make us think that treating a patient with spinal tumor while having some difficulties and presenting some challenges is definitely something that's worth considering, because when things go well, they can go quite well. And the thing we're worried about from an infarcting standpoint, the vascular damage, that is a late-term event that typically is going to be at least 12 months and more usually 18, 24, 36 months down the road. So again, we believe that the potential benefits of treating a patient with ARC therapy, with stereotactic radiation therapy, outweigh the potential risks of doing so, and do see this as a treatable tumor type. For PetCure Oncology, this is Dr. Neal Mauldin.